Thank you, Chair, for your kind introduction. The reasons for to emphasize the IR's perspective of PTA for PLD are because we IRs are good at image guiding technique. It could help us to approach lesions via versatile fashions. We performed intraluminal and subintimal angioplasty. We removed thrombus not limiting to mechanical atherectomy devices, but also by catheter, aspiration, and no urokinase thrombolysis. This thrombolytic technique is very important to help us resolve many clinical scenarios. This patient had long segmental steno-occlusive lesions in the left and ATA. Vascular rupture was complicated during a guide wire cannulation. I shifted to subintimal route immediately with successful reentry into the distal ATA after balloon dilation. A well-restored ATA was recreated. Another case of long segmental total occlusion of the right ATA after subintimal angioplasty. The occluded ATA was restored in minutes. The reentry success rate in distal runoff is very high, more than 90%. But occasionally, even with technical success, as in this case, with occluded ATA and dorsalis pedial artery, balloon dilation had been done beyond the label of the pedal loop. The DPA was still not opacified. Then I developed a technique that I inflated a 20 centimeter long, 3 millimeter balloon catheter in the proximal ATA and forcefully infused urokinase into the distal artery via the balloon catheter's tip with an infusion pump. After overnight urokinase infusion, the follow-up angiogram revealed the good patency of all the ATA and the DPA. The spontaneous guide wire reentry into the true lumen of a large artery is more difficult because the intimal flap is much thicker. This patient had a long chronic total occlusion of right common and external iliac arteries. The looped guide wire indicated a subintimal route. The red circle indicates the guide wire retained in the subintimal space with reentry failure. Under this circumstance, we require a reentry device for help. This patient had a segmental chronic occlusion of the right SFA, which failed to be crossed by a CTO guide wire in intraluminal angioplasty or by spontaneous guide wire reentry via the subintimal route. We can use an outback reentry catheter which can laterally protrude a 22-gauge reentry cannula after pushing forward the button at the catheter hub, which will pierce through the intimal flap into the true lumen, as in this patient. This patient had total occlusion of the distal abdominal aorta and the bilateral common iliac artery, the so-called Larry syndrome, which is the most challenging and complex region for endovascular therapy. After failure of spontaneous guidewire reentry into the abdominal aorta, I used an outback catheter to accomplish the bilateral reentry process. After metallic stent placement, full restoration of the vascular flow in the abdominal aorta and the bilateral iliac artery was demonstrated. If there's no outback reentry available, we can use a curved tips needle or a transeptal needle as a substitute. After advancing the tips needle in the subintimal space to the level of the patent abdominal aorta, we'll check the needle position by angio CT or combined CT. In this patient, although the occluded region is in the left common iliac artery, whereas the needle tip was on the right side aortic wall at around 9 to 10 o'clock direction. Then what we had to do was to rotate the tips needle to the 3 to 4 o'clock direction and push forward the needle tip through the intimal flap into the true lumen of the abdominal aorta. The 2 years follow-up CT after stent graft placement showed good patency of the stenting vessels. Even in a very tortuous iliac artery, this technique can be applied successfully, as in this patient. The tips needle was at 12 o'clock direction of the abdominal aorta. Then we push forward the needle tip toward the 6 o'clock direction with successful re-entry. The full restoration of the right iliac arterial flow could be accomplished in around 15 minutes. This patient had very long segmental arterial occlusion, including the right external iliac artery, femoral popliteal artery, and the rung of vessels. Conventional standard femoral approach, contralateral femoral approach was adopted to treat all the right side lesions in one treatment session. After catheter aspiration of the thrombus balloon dilation of the underlying vascular stenosis and urokinase infusion, the completion angiogram showed good patency of all the above-mentioned lesions. Besides the standard contralateral femoral approach, we can perform the ipsilateral femoral approach, artery, retrograde puncture of the popliteal artery, direct needle puncture of the patent or thrombosed dorsalis pedis artery, the occluded metallic stem can also be punctured. There's one another puncture technique that had never been mentioned before, in this patient, total occlusion of the left hepatic artery, left iliac artery, common femoral popliteal artery, and the rung of vessels. The left iliac artery could not be crossed via the right femoral approach. I punctured the thrombosed the middle third SFA with the patient still in supine position. After restoring the upstream flow, I did another antegrade puncture of the left common femoral artery to treat the downstream occlusive lesions. The completion angiogram showed good patency of all the occluded arteries till the foot region. This patient had total occlusion of bilateral iliac arteries, right femoral popliteal arteries, and the rung of vessels. I treated this patient first with the first puncture at the thrombosed right middle third femoral superficial artery, and by the aid of an outback catheter with successful re-entry into the true lumen of the abdominal aorta to treat the upper string lesions. And then I did the second puncture at the right common femoral artery to treat the downstream occlusive lesions. After removing the common femoral sheath, I found the downstream flow was still not unsatisfactory. Thereafter, I did a third puncture from the left subclavian artery to infuse urokinase with a catheter tip distal to the previous common femoral artery puncture site. The complete angiogram showed a good restoring of all the right loading arteries. This patient had right distal femur fracture post internal fixation 3 days ago, but complicated with finger cyanosis and bulla formation in the right foot. Angiogram showed the total occlusion of the right femoral popliteal artery and the rung of vessels due to external compression of a nail to the distal SFA after catheter aspiration of the thrombus. A superior stent was deployed in the compressed distal superficial femoral artery with continuous urokinase infusion. The completion angiogram showed the good patency of all the arteries in the right lower limbs. This patient then underwent ankle disarticulation with her right limb preserved. Take-home message: familiarity with the technique of intraluminal and subintimal angioplasty, versatile vascular approaches, and the clearance of the thrombus with either catheter aspiration or mechanical atherectomy devices, especially with adjunctive use of thrombolytic agent, improves the clinical success of limb salvage in treating critical limb ischemia. Thank you for your attention.